So today's topic, as you all know, it's about a new field in the. Let's share my screen. Okay, it's about rheumatological and immunological disorders. This is quite an interesting topic because all these years people were talking about neck and back, mechanical neck pain, back pain, muscles, fascia, releasing stuff. But there are some quite a good number of conditions which are actually inflammatory in nature, which are autoimmune in nature, which doesn't even come to the radar of a physiotherapist. Me, on virtue of consulting in this hospital called Chandra Rheumatology and Immunological Center and Research, um, which is a pioneer institution in the treatment and the management of rheumatology and autoimmune disorders. In the photo, you could see Dr. Chandrasekhar. He is the founder director of this particular institution, and you need to know him on for his uh, treatment accuracy, the diagnostic accuracy, and the treatment efficacy. Would you believe if I say that he's seeing close to 100 patients every day? Not usual neck pain, back pain, only rheumatological and immunological disorders. He's super busy guy. Amidst his busy schedule, he still conducts numerous researches. He has got more than 100 publications in his name, and he's a columnist. He's an editor of his own journal. He's a speaker. He's famous all over the country. He's also one of the leading rheumatologists in the South India, I would say. So me associated with this hospital with him is a privilege for me, and I am sincerely extending my heartfelt thanks for letting me explore my techniques in his own institution and on his own patients. I have been working in this hospital for the past close to 4 to 4.5 years, and I have gathered certain amount of information which I thought I should be sharing with my fellow physiotherapists, because what I learned was extremely new compared to what I used to know earlier. So this knowledge must go to the other physiotherapists as well. So with introduction, let me introduce the term called rheumatology. It's a branch of medicine that deals with diagnosis and treatment of rheumatic diseases, including autoimmune disorders. So rheumatology is a field. You don't think rheumatology is just rheumatoid arthritis. It's an umbrella term that encompasses various disorders, including rheumatoid arthritis. And rheumatology itself is a form of autoimmune disorders. And immunology is a study of immune system and its malfunctioning, like autoimmune diseases, hypersensitivity, and so on. So the rheumatological conditions and the immunological conditions are tightly interrelated. It's very difficult to separate each other. So rheumatologist should be also an immunologist, and immunologist should be also a good rheumatologist. So why this is important? Because I always thought rheumatology means only RA and ankylosing spondylitis, but it's not. It's completely a gray area in the field of physiotherapy. Because when I studied my BPT, my course curriculum doesn't cover the entirety of the rheumatology and the immunology. All we learned was RA and a little bit of ankylosing spondylitis. And when you see the rheumatology, it has numerous conditions under its umbrella. There are about 200 plus conditions which comes under the rheumatology and immunology. So it's a plethora of disorders which needs some attention from physiotherapy perspective. Plus, we have less clinical exposure to many disorders like psoriatic arthritis, SLE, Reiter's syndrome. So these are some of the conditions where physiotherapists can play a crucial role in the overall treatment process. When the patients come to you with the psoriasis, and also if you have an arthritis, now the psoriatic component can be treated by the rheumatologist, but the outcome of the psoriasis is the arthritis. Okay, that may have some musculoskeletal manifestation that can be dealt by physiotherapists. So physiotherapist has very less idea about SLE and psoriatic arthritis and so on. Plus, the PTs don't have the skill set to diagnose and refer in inflammatory disorders. Let me give an example. I got a patient who was about 60 years when she met me, and she was got pain all over her body, like every joint was painful. And I asked her, "No, why you have this much pain all these years and you didn't meet a rheumatologist?" She said, no, I'm good with my homeopathy doctor. So I'm taking homeopathy treatment for a long time, close to 5 years to 10 years. She has been taking homeopathy medicine, wherein when we did the blood test, we found that she's having rheumatoid arthritis positive, RA positive, and anti-CCP positive. It's super positive for rheumatoid arthritis, and she never took any medicine for rheumatoid arthritis. But even before we introduce any medicine, already the joints have got deformation, some irreversible damage has happened. So it could have been easily prevented. So what I tell is, the physical therapist should have some basic skill sets to diagnose some form of inflammatory disorder, so that they will know when to refer or when to treat, which we'll be discussing in the forthcoming slides. But the intent of this entire webinar is to give the physiotherapist an understanding and orientation about the common rheumatological and immunological disorders, wherein they can decide whether to refer or to treat. So these patients, these rheumatological patients, let's say if a patient has got scleroderma, or a patient has got polymyositis. Okay, these patients, though polymyositis is a condition characterized by inflammation of the muscles, these patients may have weakness of the upper girdle muscles. They may not get physical therapy referral. Since the patients are not referred to the physical therapist, the physiotherapist doesn't have much idea about these conditions. So, since they don't get the conditions, they don't have any necessity to learn. Let's say we spend a lot of time on learning neck pain and back pain because we see those kinds of cases every day in our clinic. But we don't get cases like ankylosing spondylitis or scleroderma or polymyositis every day in our clinic. That's the reason why PTs are not having that much awareness or knowledge in this particular field, which should change in my understanding. Hopefully, in the near future, it will change. So, largely treated by medications only. These patients would be largely treated by medications. Let's say a patient with ankylosing spondylitis, rheumatologist will be giving the disease-modifying drug. But the moment inflammation strikes a joint, the joint will start developing mechanical pain component. So every inflammation may have mechanical component, and such mechanical component shall be or will be treated by physical therapists alone. Little bit of nutritional and psychological part, but inflammatory arthritis needs some mechanical management too, which can be done by physios. And plus, every case is different. No two rheumatoid arthritis or no two ankylosing spondylitis are alike. So every patient is different in his own way. So our PT protocol also should be accordingly varying. Now, the rheumatological disorders, as I mentioned, it's a broad term which encompasses various conditions under that. Now, I have made the slide simple, but the classification itself is very, very complex. But this is my one way of classifying the rheumatic disorders. You can broadly classify rheumatic disorders under inflammatory and non-inflammatory. So inflammatory disorders, it includes rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, reactive arthritis, enteric arthritis, gout, pseudo-gout, septic arthritis, and systemic lupus erythematosus, shortly called as SLE. Apart from that, there are other inflammatory disorders. For brevity purpose, I didn't include that, but there are many more inflammatory disorders. Coming to the non-inflammatory disorders, we have arthritis and osteoporosis and fibromyalgia, hemophilic arthritis, traumatic arthritis, and Charcot's joint, otherwise called as neuropathic arthritis. So physios are very good in treating non-inflammatory like fibromyalgia and osteoarthritis. But it is also important that we focus our attention to the inflammatory component also. Now, what are the signs of inflammation? Now, we all know that inflammation is the sign of something abnormal happening in the body. The body is on fire. Let's say when someone sprains their ankle, the ankle will be on fire. Why? Because that's a tissue trauma. Body is trying its best to heal it. So automatically there will be a blood flow there. The swelling will be there. Pain will be there. Loss of function will be there. So we call that as rubor, color, dollar, tumor, and functionalacia. Okay, where color means heat, rubor means redness, tumor means swelling. So these are the characteristics that we see in our ankle sprain patient. But these are the characteristics that will be presenting in inflammatory arthritis also. Now, when someone comes to you with an joint which fulfills all the 5 categories, rubor, color, dollar, and functionalacia, then we need to probably think in inflammatory perspective also. When the joint is on fire, you must do something to reduce the inflammation. Of course, we do give ice pack and ultrasound. That's a common treatment used by physical therapists, but the inflammation should be controlled from within inside. Whatever we do outside the joint, the inflammation is from within the joint. So that component has to be addressed. So the inflammatory arthritis, but this slide should make you understand that whenever you get a patient, okay, look for these signs of inflammation. If these parameters are there, keep it in your mind that there are signs of there is an inflammation going on in the joint, and that inflammation can be anything. It can be an RA, it can be an enteropathic arthritis, it can be a psoriatic arthritis, it can be a gout, it can be a septic arthritis. But every inflammatory arthritis will have this thing in common. Okay, so we know that the joint is on fire. We don't know the reason for the fire. We need to find out. Of course, our job is not to, our onus is not to diagnose all the condition, but to at least know the basics of these inflammatory conditions, so that we know when to refer and when not to refer. Okay. When an old lady comes to you saying that, doctor, I have been having this pain for the past 6 years, and I have been having this pain both of my feet and both of my ankle, both of my hands, means you need to probably think, okay, it could be a female, maybe bilateral involvement, small joints are involved, so it could be rheumatoid arthritis. You need to ask, did you check your rheumatic factor? Did you ever do a blood test? So it's easy to get these things missed. Okay, so it will be a waste of time if you keep on treating them when they themselves need some other treatment. Okay, so the inflammatory arthritis manifestation, every arthritis, especially the inflammatory arthritis, will have both extra-articular and articular manifestation. In ONE, you don't have to worry about the eyes or the skin or the nails, but in inflammatory arthritis, there will be an extra-articular manifestation. What are the extra-articular manifestation? It can affect the tendon, like ankylosing spondylitis people will have an enthesopathy. Okay, in fact, both the sides will be symmetrical enthesopathies at the Achilles tendon. Skin, they will be having dryness of the skin in certain conditions. Nails, there will be pitting in the nails or dryness in the nails, which is common for psoriatic arthritis. Uveitis, conjunctivitis is common for Reiter syndrome. Inflammatory bowel disease is one of the form of spondyloarthropathy. So inflammatory arthritis will have an extra-articular manifestation. So when you are assessing the patient, you can also ask certain valid questions. Can you show your nail? Do you have eye issues? Do you have intestinal issues? Do you have frequent tendinitis? Now, I was treating a lady who used to have Baker's cyst, who used to have early morning joint stiffness, who used to have recurrent Achilles tendinitis. So eventually we found that she's having RA. Now, but I was wrongly treating her in the mechanical perspective, thinking that no, the load is more. She did overwork at the home. So we were wasting time on that. So then we realized that no, she was having a RA factor positive, and then we sent to a rheumatologist, and now she's doing very well. So some other conditions has to be managed like that. Okay? Articular manifestation, it is common for both inflammatory and non-inflammatory arthritis. You all know articular means it's a joint which involves synovium, synovitis, cartilage erosion, periosteal erosions. Articular surface itself can get thinned in rheumatoid arthritis. There will be a obliteration of the articular surface causing deformities, and even there will be a bone erosion too. So inflammatory arthritis will have both articular and extra-articular manifestations. Now, this is an important slide which discriminates which is your patient to treat, which is the patient which should be referred. Okay. Inflammatory arthritis, common example is rheumatoid arthritis. Non-inflammatory is osteoarthritis. The cardinal signs of inflammation would be there in the inflammatory arthritis, like rubercular, Dollar tumor, and functional aschia, which won't be there in the non-inflammatory arthritis. Or in non-inflammatory arthritis, they may be having swelling here and there, but they are not the primary reason for the pain itself. Okay. And inflammatory arthritis will be symmetrical in nature, like because the autoantibodies in the blood, it doesn't discriminate sites. Okay, whereas the non-inflammatory arthritis, it's a biomechanical arthritis, right? It's mechanical change. So it will be asymmetrical. Which side the load is more, that side the pain will be more. That side the inflammatory arthritis, it will be symmetrical. Why? Because the autoantibodies in the blood, which it will not discriminate between right and left, it will affect both the joints. In fact, it affects the non-weight-bearing joint. If you see the osteoarthritis, it affects the weight-bearing joint, knee joint and hip joint, whereas in non-inflammatory, it doesn't care about the weight-bearing, non-weight-bearing. It just affects any joint, usually the small joints. And worse in the morning, more stiff in the morning. Beyond 60 minutes, if they have stiffness, that is classified under inflammatory. And if it is less than 60 minutes, it's non-inflammatory. Okay. And there's a small catch here. People who are having mechanical back pain also will have early morning stiffness, but their early morning stiffness may not extend more than 60 minutes unless until it's a very severe disc herniation. The early morning stiffness will be less than 60 minutes, whereas in inflammatory it will be more than 60 minutes. And what is ESR and CRP? These are all the inflammatory markers. It will tell that whether there's a fire going on or not. It will not tell why the fire is, whether the wood is burning or the paper is burning or cloth is burning. It just shows it is burning. That's all. What is burning? What is the reason for the burning? Nobody knows. Even if you have an infection, you will have ESR and CRP elevated. Whereas in non-inflammatory arthritis, ESR CRP will be normal, and inflammatory is non-mechanical and non-inflammatory is mechanical, because mechanical means it's due to your posture, movements, activities, whereas this is nothing to do with the activity. Fine. So the wrist and hands are more involved. Non-weight bearing joints, here the weight bearing joints are involved. Activity improves pain and stiffness because as they move, the inflammatory exudates which are accumulated in the joint will get washed away. Whereas in non-inflammatory arthritis or in our classic ONE, patients tell that, doctor, as I walk, I get worse and worse that I could not walk. So that's one of the classification, that one of the principles that we use to decide whether it's inflammatory or non-inflammatory. Extraarticular symptoms are normal, common in inflammatory, whereas it is not in the non-inflammatory. Okay, so deformities is there in inflammatory, whereas it is not very common in non-inflammatory. All right. So the rheumatological disorders based on joints involved, we call that as now. If a patient come to you with isolated knee pain, we call that as monoarticular involvement or monoarthritis. Okay. If a patient come to you with two joints involved, we call that as oligoarthritis. If the patient come to you with multiple joints involved, we call that as polyarthritis. Now, have you heard of gout? Okay, patients would come to you with a single joint involvement. Usually, the first metatarsophalangeal joint would be involved. Or when a patient has a TB hip, or when a patient has a septic arthritis in the knee joint, usually it will be only one joint. So just because it is only one joint, you can classify under monoarthritis. All right. And if it is a monoarthritis, you can conveniently rule out rheumatoid arthritis and systemic lupus erythematosus. Okay, this is ruling out by elimination principle. If the patient comes with only one joint involvement, you can conveniently rule out rheumatoid arthritis and SLE. Oligoarthritis are like psoriatic arthritis, enteropathic arthritis, reactive arthritis, which we'll be discussing in the forthcoming slides, but they will be involving 2 to 4 joints. Polyarthritis, you all know, rheumatoid arthritis will involve more than 5 joints. Okay, so this is the classification of the joint disorder based on the number of joints involved. About the classification in terms of acute and chronic, some patients come to you with joint pain in a very acute sense, like less than 1 week, less than 2 weeks. People with gout, pseudo-gout, septic arthritis, reactive arthritis, acute exacerbation of ONE, and acute flare-up of RA. So these are all the people who come to you in very early during the episode. Whereas in the other side, when someone says that I have been having this problem for the past 5 years, doctor, I have this for the past 10 years, then you can if someone who is having pain for 10 years, they will not have septic arthritis. If someone has pain for 10 years, they will not have pseudo-gout, they will not have gout. So in that way, you can rule out that they don't have any acute form of arthritis, they have chronic form of arthritis. What are the chronic form of arthritis? Here we are. It can be in RA, it can be in AS, it can be in SLE or psoriatic arthritis or chronic gout or even ONE. Okay. And some are symmetrical, some are asymmetrical. Your ONE can be asymmetrical because right and left joint cannot be wear out very evenly. Always there will be one side more severely affected than the other side. Similarly, there are some inflammatory diseases which has asymmetrical pattern, like gout, asymmetrical pattern. Septic arthritis, it will affect only one side. You won't see people who are having septic arthritis on both the knees. You won't have people who is having a pseudo-gout on both their foot. It will be only one side. Okay, so asymmetric arthritis are this category. You can rule out if someone has a pain only in the one side, you can rule out the symmetrical arthritis like RA, SLE. Post-viral arthritis, you all know. I think some of you might have experienced post-viral arthritis. Pain will be all over the joints. It doesn't discriminate sides. Okay, you will be having bilateral foot pain, bilateral knee pain, bilateral hip pain, and so on. Okay. Now, this webinar is to make the physio to understand the importance of the knowing these rheumatological disorders, because if you are a musculoskeletal physiotherapist having close to a decade or 2 decades of experience, you may be, because you are getting popular and popular, you may get patients who are not actually going to need the physiotherapy, but still they meet you because you are getting popular. Plus, if you are working in an urban, a rural, or a semi-rural environment, or a rural village where there are no much good physicians, then the physiotherapists are the one who should actually act like a physicians in order to probably guide the patient in the right pathway. Okay, so patients, especially when they have an acute monoarthritis, that time they tend to come. I get so many patients with acute monoarthritis. Doctor, I did sudden stair climbing, I got knee pain. Suddenly, I woke up in the middle of night with ankle pain. So these patients might even have inflammatory arthritis, which can be wrongly misdiagnosed as a mechanical pain. Okay, so now as we evolve in our field, we should become more of a diagnostician, because we have ample techniques in the field, but we don't have much knowledge about how to properly evaluate a patient, how to diagnose them, how to discriminate whether they need physical therapy or they need a referral. Okay, so for that, this knowledge is important, because if you misdiagnose a condition, you will be unnecessarily delaying the treatment. And some conditions, if you delay, like for example, if it is a septic arthritis, if you delay for 48 hours, 48 hours of delay in septic arthritis will produce irreversible damage to the joint. It's about preserving a joint, isn't it? You should not just let the joint to erode. So early intervention is important to prevent irreversible joint damage. An inflammatory joint, as I said, inflammatory joint will have a mechanical component which needs addressal, but not before addressing the inflammatory component by medical means. And plus, rheumatology, since I go there now, we see it'll be like a market in the hospital. So many patients will be there with inflammatory disorders. I would be wondering where these patients were in this world. Suddenly everybody are in one place, because those many patients are there in the world with inflammatory disorders. But unfortunately, those patients are not directed to the physical therapy clinic. It's completely an untapped area with greater potential. So physios must learn the basics of inflammatory joint disorders, because inflammatory joint disorder is a MSK disorder, isn't it? Though we are experts in mechanical component, we should be able to analyze and observe and know the basics of the inflammatory component also, so that we'll be knowing when to treat and when to refer. Now, I'll be going through some of the common and uncommon inflammatory disorders. It may be little overwhelming, little elaborate, little jargons will be there. I'm sorry for that, but for the completion's sake, I have to do certain things. But I'll try to keep as simple as possible. Okay, so please be with me for next half an hour to 40 minutes. So the rheumatoid arthritis, you all know, it's a very famous inflammatory disorder. This is the one of the form of, it's autoimmune, because body's own inflammatory cells will attack its own cells. It is systemic in nature, because it is not only a joint problem. It affects organs, it affects lungs, it affects skin, it affects eyes, and so on. It is symmetrical in nature, because it affects both the sides, and it's chronic. No RA is acute. Though it starts as an acute, but people will progress to the chronic stage eventually. And it's an inflammatory polyarthritis. So it's not autoimmune, it's systemic, it is symmetrical, it's chronic, it's inflammatory polyarthritis. And amongst all the inflammatory disorders, RA stands first in terms of the commonality of the inflammatory disorder. RA is number one, which affects the small joints and more common in the female group. And as you know, in inflammatory disorders, will have early morning stiffness more than 60 minutes. Just because they're having early morning stiffness, if they are females, if they have symmetrical joint involvement, small joints involved, you can more or less diagnose it as RA. You just have to ask them to go for blood test and confirm it. Okay? It has both articular and extra-articular manifestation. Now, the prevalence is 1 in 100. That means, let's say in Bangalore, if it is 1 crore population in Bangalore, at least close to 1 lakh people are there, isn't it? So where are these people? Are they getting PPT treatment? So many people are there who needs, even though half of them are medically treated, some will have joint manifestation which needs physical therapy intervention, isn't it? So it's a huge potential. And the incidence starts from 20 to 25, though it will be waxing and waning on and off. So pathophysiology, I will not bore you more, and I do understand there will be an antigen antibody reaction. The antibodies will be produced against own body cells, and it specifically targets certain areas of joints. So it can result in synovitis, it can result in release of cytokines, and finally the joint will go for erosion, fibrosis, and ankylosis. So the clinical features, as you know, symptoms will be greater than 6 weeks. Synovitis is the hallmark sign. Rheumatoid arthritis is mainly will be affecting the extra-articular structures as well as the articular structures. What are the most commonly involved joints? MCP and PAP. Remember, DAP will not be getting involved in RA. Okay, DAP is reserved for some other arthritis. I will come to that later. But commonly MCP and PAP. I do simple tests, because some of my patients will tell that, doctor, when I wake up in the morning, the hands are very, very stiff. I have to do this. Okay, it can be a form of neuropathy because they'll have more stiffness in the morning. But I ask them to do this, or I personally I do this. If I do this, if I squeeze the hands and if they say, doctor, it's very painful. No, they say, then that shows that there's a diffuse inflammation going on in the hands. Then I ask them, will you be able to break knuckles? Okay, if they are able to break knuckles, we know that the integrity of the boundaries of the joint capsule integrity is patent, it's intact. The moment synovitis happen, the joint integrity will be lost. So you won't accumulate gas in the air, so you won't be able to break knuckles. So unable to break knuckles is one of the signs that I always personally consider as one of the warning signs that they are having small joint arthritis. But of course, the real test is RA factor and anti-CCP. But these are some of the simple tests you can do in your clinic to know whether they need referral or they need your treatment. Fine. So apart from that, they may have tenosynovitis, trigger thumb, carpal tunnel syndrome, and in extreme cases, they will have even joint deformity, subluxations too. I was seeing a patient who came for some other reasons, but he was a known RA patient. You know what he said? Doctor, I got neck pain once. I went to a physio. He put me in the traction machine. You know what? I developed quadriparesis. Do you understand why? Because he's a known RA patient and you put him in traction. You know what RA can manifest in the neck? It's atlanto-occipital subluxation, because when patients are having more than 5-6 years of rheumatoid arthritis, slowly it will affect the synovial joints. And in the spine, the only synovial joint which is more vulnerable in the spine is the atlanto-occipital joint. So it was already a little unstable. Okay, this novice physiotherapists have put traction and patient developed quadriparesis. So he had to undergo an emergency surgery. Now, would you want you to be in that position? No, right? So at least if you don't do any good, don't do bad, isn't it? So it's quite easy to you could have prevented it just by applying common sense. So always do remember, when the patients are coming to you with neck pain, and if they already have a rheumatoid arthritis history, don't give traction, or you can do a sharp pulses test to know that whether they have an instability or not. And then you have to be very careful, and you don't have to even do any grade 5 or grade 4 manual techniques in those patients. Okay. So deformity wise, it can be any. I have compiled all the deformities, but there could be a botanist deformity, there can be an ulnar deviation of the MCP joint, swan neck, and there can be a subluxation of the joints, and anything can happen in this patient. Depends upon how early the medications have started, or how severe the disease manifestation is for them. Not every RA patient will develop deformity. Not every patient will progress to the last stage, and depends upon so many factors. So the clinical features, these are the extra-articular features. I don't want to read everything, but do understand they'll be lean, thin, weight. They'll be having weight loss issues. As I said, some patients' mortality is due to the cardiac problem. They are more prone for coronary artery disease, so they have to take extra care in terms of their cardiac health. And they may have pleuritis and conjunctivitis, scleritis, even carpal tunnel syndrome is also one of the extra-articular manifestation. And this is very common. Some patients in our clinic, we see this. Some patients would have subcutaneous nodules. In the back, usually you see that. Even during my course, people ask, doctor, students will ask, there is a knot there. No, what is that knot? Is it a trigger point? No, I thought it's a fat ball. Fat ball is nothing but the lipoma. Okay, lipoma developed under the subcutaneous area is a tendency. That's an inflammatory tendency. It's quite common in people with inflammatory disorders like AS or SLE or RA. Okay, but it won't express every time. Sometimes it will get inflamed. So one of the feature is subcutaneous nodule, which is soft, rubbery, and non-tender. Usually painless, but sometimes it can get inflamed. Okay, according to American College of Rheumatology or European Union, European League Against Rheumatism, if they have positive history and physical condition, do understand. I have seen people with a positive rheumatic factor doesn't develop RA. Okay, but if they have RF factor positive with anti-CCP means anti-cyclic citrulated protein. So CCP is very specific, means if they have it, then you can rule in rheumatoid arthritis. If RF factor is negative, you can 90% rule out rheumatoid arthritis, but still 10% here and there that false positivity is there. Now, who will have worse prognosis? People who are having RF factor positive, anti-CCP. Anti-CCP it's a protein that will be there in the blood. In the usual RA panel test, they will be doing anti-CCP along with RA factor. So RF plus anti-CCP plus extra-articular, if they have one extra-articular manifestation, then you can assume that they'll have worse prognosis. And ESR in CRP, it will be high. ESR CRP will be high in every inflammatory condition. Okay, so this alone will not tell anything. This plus this will confirm the diagnosis. Now these are some of the X-rays that we see. You see how much is the dislocation, how much is the subluxation, what is the see the ulnar deviation of the MCP joints everywhere. Actually, it is a crime if we let the patient to progress to this stage, because we have so much of advancement in the medications nowadays that we have disease modifying drugs and biologics that you can actually avoid worsening of the condition. Okay, in earlier days it was not so advanced, but nowadays if the patients are rightly identified and addressed very early, you can prevent this. Okay, you see this is not ONE. It's very easy to see ONE. It's not, you can't see any ONE like that. It's an erosion. You see the joint margin is completely obliterated. There's a new bone growth there. So this is a classic RA, which needs definitely TKR, isn't it? Because it's very much eroded and swollen. Now, treatment, Dr. Sasi will be discussing more about treatment, so let me not dwell deep into that, but usually they need steroids and DMRs and so on. Now, this is one thing, spondyloarthropathy. I always was intrigued about spondyloarthropathy. What is spondyloarthropathy? And because people used to this term spondyloarthropathy, but spondyloarthropathy is a combination of these conditions. We can use the mnemonic called PAR. Okay, P stands for psoriatic arthritis, A stands for ankylosing spondylitis, I stands for inflammatory bowel disease, which can cause enteropathic arthritis, and R stands for reactive arthritis. So what they have in common? They have HLA-B27 in common. So if the patient has HLA-B27, they have high vulnerability to develop any of these conditions, even though ankylosing spondylitis is the most commonly obtained condition out of this HLA-B27. Okay, and remember, these are all seronegative condition. What is seronegative? If the patient has RA negative, if the patient has anti-CCP negative, then that is called seronegative. So if the patient has multiple joint involvement and still RA negative, means maybe you need to think of this form of spondyloarthropathies. Ankylosing spondylitis is quite easy to diagnose, but reactive arthritis and enteropathic arthritis, it is diagnosed only with your HLA-B27 and the negative findings in the RA and anti-CCP in the blood test. Okay, so remember this PAR. PAR stands for family of spondyloarthropathies. Ankylosing spondylitis is quite common condition, but I have seen 4 or 5 ankylosing spondylitis patients in the hospital. In my hospital, where when I ask them to turn, they turn like that. They didn't even have a single degree of movement in the neck. Why? Delay in the treatment. Okay, improper treatment. No physical therapy referral. Ankylosing spondylitis need in medical management and right timely physical therapy management. If you allow it to worsen, the moment it becomes stiff, it is an articular stiffness. You will not get it by manipulation. You won't get the range back by cracking the. You can't even crack the neck or crack the spine to get the range because they're all bone fused. Okay, so it needs proper medical and proper physical therapy intervention. So that's the reason why ANCI stands for fusion. Spondylitis stands for inflammation. Spondy means, and it's all about spine. Itis means inflammation. So spondylitis means inflammation of the spine associated with fusion of the joint. So combined, it's called as ankylosing spondylitis. Of course, it is a chronic condition because no one will come to spondylitis with acute. No one will be saying that I have spondylitis for past 2 weeks, nothing like that. And they are seronegative because RF is negative for them. It is an inflammatory. You will see all signs of inflammation. Okay. I have seen a cricketer who had bilateral enthesopathy in his foot. Every time he plays, he will have severe pain. I have even recently shared that X-ray in my WhatsApp group. This guy happened to be having HLA-B27 positive. So he was thinking that because he's a player, why players doesn't get HLA-B27 positive, players doesn't get ankylosing spondylitis. No, they also will get. Just because circumstantially they have got into the sports doesn't mean that they can change their gene. Okay, so we identified that he was having ankylosing spondylitis, and then we started the medications, and then he was playing very well with the right medications. Okay, so keep your eyes open. It can be anything. Okay, we are so much tunnel vision sometimes that every pain is disc in nature, every pain is mechanical in nature. Sometimes it can be inflammatory also. Okay, and it's an ankylosing spondylitis is an axial form of arthritis because it affects the axial spine more commonly than the appendicular spine. Though ankylosing spondylitis can affect the hip and knee joint, that's very rare compared to the spine. Okay. So, 0.2% of general population. If Bangalore has 1 crore population, we have about 20,000 ankylosing spondylitis patients. Okay, where are they? We must treat them, but not all. One more example I will tell. I had one patient with back pain who classically fitted into the mechanical back pain category. Early morning stiffness, pain in the buttock, pain going to the thighs, SLR positive. Neural tension positive, tingling numbness in the leg, but he also happened to be having HLA-B27 positive. Because usually this guy he did all the tests, and then one doctor told him to do HLA-B27. Unfortunately, that HLA-B27 got positive. Now that went into his mind that for about 2 to 3 years until he met me, he was thinking that he was having ankylosing spondylitis. So it took a lot of time for me to make him understand, and only with my intervention, as he got better, he realized that his pain was not due to ankylosing spondylitis. His pain was mechanical in nature. Because I know both of this inflammatory field and mechanical field, I could be able to communicate with him better. Okay, so don't think that all HLA-B27 patients who get back pain is because of ankylosing spondylitis. You need to still evaluate. You need to check and decide whether it's falling under the mechanical category or inflammatory category. Okay, but there are other cardinal signs where you can really conclude that they have ankylosing spondylitis. But I thought I'll use it as an example so that you can be vigilant always in the clinic. Don't take it for granted anything. Okay, that's very important thing. So 90% of AS patients will have HLA-B27 positive, but not all HLA-B27 positive patients will have AS. Okay. In fact, the HLA-B27 prevalence is 8 to 10% in the overall population. You understand, but not everybody will get AS. And of course, males are more involved than the females, and more prevalent in Caucasians and less in Africans. And it affects very young in the young age. You see here the healthy vertebra with a proper disc and vertebral bodies and so on. Slowly, inflammation will set in the joints, and then there will be a bone spur forming, and then the bone spurs will obliterate the joint space, and there will be a fusion of the vertebra. Now, if the patient says that if he is an young patient coming to you with a sacroiliac joint pain, early morning back stiffness, no mechanical pain, no neurological signs, then you must be asking him whether he has anybody in the family having HLA-B27 positive or ankylosing spondylitis, so that you can do a right referral. I have seen people who are really doing very well as they were identified very early during the course of the disease. The early identification and early treatment is the key in ankylosing spondylitis. Once it is progressed to a certain level, it becomes irreversible. You won't get that back. Once it is irreversible, it is irreversible. You cannot change anything after that. You can preserve, but you cannot reverse. All right. So low back pain starts as the SI joint. SI sacroiliac iliacis is the cardinal. It all starts as a sacroiliac inflammation. Restricted mobility, sometimes kyphotic deformity in the late stages, and rarely it will go to the hips and the knees, including enthesitis. Okay, extraarticular features are, as I said, every inflammatory arthritis will have an extraarticular feature. Extraarticular features will help you to double confirm the diagnosis. Uveitis, scleritis, Achilles tendinitis, because I am keep on telling about Achilles tendinitis because we all tend to think Achilles tendinitis is a load-related problem. No, if the inflammatory tendency is there, even a smallest load can cause more inflammation. So even plantar fasciitis, especially when Achilles tendinitis occurs bilaterally to an young population, which is not in line with the load, then you need to think of inflammatory issues. Dactylitis is an inflammation of the toes, and some will develop psoriatic tendency too. And with ankylosing spondylitis, people generally they'll be, as the condition worsens, it will affect the organs, it will affect the intestine, so they will lose weight and they'll be fatigued and tired. Usually they'll be thin as they progress in terms of the disease. And it has manifestation in the heart, iotitis, heart blocks, and so on, IBD, ILD, and so on. Why it should be treated? Because sometimes in earlier decade, the mortality is quite high in ankylosing spondylitis. People die out of cardiac problem or the pulmonary problem. But now, because of the drugs advancement in the drugs, such mortality is less. But they are living with so much morbidity. Okay, so that has to be prevented. These are the complications because the bones are getting too thin. They get pathological fracture. Sometimes they'll get spontaneous, out of no reason they'll get pneumothorax, because one of the reason is as the chest is getting compressed, the chest mobility tend to get reduced, isn't it? As the chest mobility is reducing, the intra pulmonary volume itself will be reduced, but the lung want to expand, the skeletal want to compress. So there will be a fight. Sometimes the pleura ruptures, and then they get spontaneous pneumothorax. Restrictive lung disease is one of the form of manifestation, stroke, heart attack, and so on. Rarely it causes a nerve manifestation causing cardiac annihilation. Diagnosis, low back pain for more than 3 months, incidence onset, young people coming with stiffness in the back, Sober's test positive. You see this, tragus to the wall test, you know this. Nowadays, even young people fail in this test. You know why? I have seen a softer guy in his 30s, he simply could not retract his neck. Okay, because of too much of forward neck posture, people have forgotten how to do this. Okay, so this is a test which is earlier where they were using for ankylosing spondylitis, but now I would consider that it is having very poor reliability for ankylosing spondylitis. So as the Fabus test, because Fabus test will be positive in many conditions. So best is Sober's test, and go with other parameters like HLA-B27, family history very importantly, elevated inflammatory markers, and so on. Okay, same thing. Let me discuss about the radiological findings. So these are the American New York criteria for ankylosing spondylitis. They'll be having both sagittal and frontal plane restriction, limited chest expansion, and stiffness more than 3 months old. Now, how to read the X-ray of ankylosing spondylitis? I generally doesn't like to read the SI joint X-ray because it's so confusing, and it'll be so much of false positive and false negatives. But this you cannot miss, isn't it? This you cannot miss. You could see a solid fusion here, a solid fusion here. This is the end stage ankylosing spondylitis, where there's a complete fusion of the SI joint. Whereas if you see the grade 3, these are the grades 0, 1, 2, 3, 4. 0 is normal, where you see there's a clear cap and the lines are smooth between the iliac and the sacral region. You see the lines are fuzzy here, lines are fuzzy here, little bit of sclerosis, little bit of erosion. Okay, so this is grade 3, but grade 1, grade 2, it's very difficult to clearly demarcate. But grade 5, definitely you can. If you see this, you can say, okay, the disease is complete, that it's gone to the fusion stage. Okay, just by seeing this, you can conclude that he is having AS. Okay. I mean, this is about the CT scan. I mean, the CT scan, you see the normal joint here, the clear line, clear joint line, no sclerosis. But you see, this is unilateral. You could see this is a, this is a bilateral sacroiliitis. Roughened margins here. This is erosion, and this is this white patch. It's sclerosis. Sclerosis plus erosion are the hallmark. Now, bamboo spine very common, and this is called as Dagger sign. Means what? Well, you could see the central line here, the whitish central median line in the course of the spine. This is the calcification of the which ligament? I know, you can't talk, but the ligament is supraspinous ligament and the interspinous ligament. Okay, calcification of the supraspinous and interspinous ligament will cause the dagger sign. Bamboo spine, you all know. Squaring of the vertebrae, you know. Shiny corners, and you see shiny corner. Okay, the sclerosis is so thick that it makes the bodies very shiny. Okay, so just by seeing this X-ray, you can diagnose that he is having ankylosing spondylitis and syndesmosis. And poor guy, this guy, the ankylosing spondylitis has progressed up to the cervical spine. It all starts at the sacroiliac joint, goes to the lumbar spine, thoracic spine, affects the chest, and finally goes to the cervical spine, affecting the cervical range of motion. Actually, this should not happen if the patients are addressed very early, but poor patient, fine. The MRI is also you don't have to do every investigation, but whatever you have in your hand, some patients will come to you with an MRI in the hand, you should be able to little understand it. Some people will come to you with the X-ray, so we should be ready for everything. Okay. You see, it's a complete erosion of the SI joint. Management will Dr. Sasi will be discussing on that. But do understand, physical therapy is a must for all forms of ankylosing spondylitis at all stages. In fact, even if the patients are taking medicines, even if the patients are doing well, every 3 months once the patients with ankylosing spondylitis must see a physio to check whether the chest mobility is maintained, to check whether the intervertebral movement, the face joint movements are maintained, the spine movements are maintained. Silently, they'll be losing the range. Nobody knows. And all of a sudden, after 6 months, you see there'll be a gross movement restriction. Okay, so in part B, we'll be discussing on all the treatment protocol, but I'm just saying that physical therapy is too crucial in patients with ankylosing spondylitis. And one more thing is identify the disease very early. I had a patient. No, I discussed this patient in my WhatsApp group earlier. This guy was having ankylosing. One guy was having ankylosing spondylitis for what? Close to 5 to 7 years, and nobody treated him. He went to physician. Physician gave normal medication, normal NSAIDs. Okay, they took all the tests except HLA-B27. Okay, and nobody knows that he has got ankylosing spondylitis. But the moment he met me, by looking itself, we identify that he's got ankylosing spondylitis. Sometimes the patients are very, very unlucky that they meet a wrong physician, and then they are screwed for their entire life. So early identification is very important. And then, in the family of spondyloarthropathy, we discussed the ankylosing spondylitis. The next one is the Reiter's syndrome or reactive arthritis, which is the arthritis as a result of previous inflammation. Now, what is reactive arthritis? It reacts. The body reacts after a recent infection. Who is affected? Males are more commonly affected. Is it seronegative? Yes, because RA factor will be negative here, ANA will be negative here. It is seronegative. But HLA-B27 will be positive. And I got a patient for 1 month back where he got only one joint pain, monoarthritis. Okay, in fact, reactive arthritis can have multiple joints, but this guy came to me with monoarthritis. There was a huge swelling in the knee. On the look itself, you know that it's something abnormal. Okay, you cannot treat them by hot pack or cold pack or IFT because it's so apparent that it's swollen. Okay, then we thought it could be an acute flare-up of his old joint. He was saying about knee injury earlier, so we were thinking in that line. But eventually, we found that he had a family history of HLA-B27. His father was having HLA-B27, but never got affected by ankylosing spondylitis. But this guy had got a recent infection, genitourinary infection, which had resulted in the form of reactive arthritis. Okay, it's very difficult to predict in these lines now unless you know little bit of this arthritis so that you keep your mind open. And then we sent him to a rheumatologist, and then he started the disease modifying drug, and now he's getting almost all right. So reactive arthritis is the arthritis which is reactive in nature as a result of any previous infection like Salmonella, Shigella, Gonorrhea, Chlamydia. These are some of the bacteria that can trigger the body to affect the joints. Okay, and it's asymmetrical in nature. It has both articular and extra-articular in manifestation. There's a saying that there's a funny saying that people with Reiter syndrome, Reiter syndrome and reactive arthritis, they both are one are the same. Old name is Reiter syndrome, new name is reactive arthritis. So, funnily, they say that patients with Reiter syndrome cannot see, cannot pee, cannot climb a tree. Cannot see means they have eye issue. Cannot pee means they have an issue with urethritis. Cannot climb a tree means they have issues with the joint. And dactylitis, this is extreme case of reactive arthritis where you see isolated finger involvement, swollen. It's called as dactylitis. Dactyl means finger, dactylitis means inflammation of the finger. Enthesopathy, again, it's common. Arthritis, of course, the joint will be tender, warm. It will fulfill all signs of inflammation because it's an inflammatory arthritis, isn't it? Along with that, they may have associated back pain or sacroiliitis. Plus, it's malaise and fever because of the previous infection. And usually, this condition is self-limiting in nature. But if not, then it needs an intervention like medicines and NSAIDs or DMRDs. Investigations, as I said, actually will be positive. You just have to rule out RA. That's all. You rule out RA so that you know that it's sero-negative arthritis. Blood test will reveal the previous bacterial infection, and ESR and CRP will be anyway elevated because you know that things are on fire. So always ESR and CRP will be elevated. Okay. All right. X-ray wise, you'll see syndesmosis because it will react little like ankylosing spondylitis. You see, these are all signs of Reiter arthritis. As I said, treatment self-limiting in nature. Wait and watch approach is good. If not, then gradually they need steroids or to begin with NSAIDs and gradually to disease-modifying drugs. Last stage is steroid. Okay. Now, any of you have seen psoriatic arthritis patient? Okay, you might have seen patients with psoriasis sometimes, but you know what? If people are affected with psoriasis and if they are not managed well, within 10 years, they will develop arthritis. Okay. So, psoriasis is quite prevalent, and 10 to 20% of patients will get arthritis at some point in their life. Okay. Don't think psoriasis is a skin infection. It is never an infection. It is an autoimmune disorder. So it is not a contagious disorder. It won't get spread from person to person. Though it looks little yuck and ugly, but it is not going to spread to others. So it is definitely inflammatory, seronegative because RA is negative here, autoimmune because body cells will attack its own cells, chronic and progressive in nature. Again here, HLA-B27. So don't think that HLA-B27 is only for ankylosing spondylitis. It is for spondyloarthropathy. So it can be even positive for psoriatic arthritis. But usually it will be waiting for an environmental trigger like trauma, infection, depression, life event. Some trigger will be there that will initiate the cascade of the psoriatic event. All right. These are the you need to ask, if you suspect of psoriasis, just ask them to show their ear to look for any symptoms in them, because psoriasis will cause some skin lesions in the ear or some scaly rashes on the skull or on the nails. You see here the pitting in the nails. This is one of the hallmark signs for psoriatic arthritis. Okay, but again it varies in severity. So if left untreated, it will go to a arthritic state. What will happen? Again, once it reaches the arthritic state, it's inflammatory. Early morning stiffness affects both spine as well as peripheral joints. Pain even during rest, swollen joints. Ankylosis is this, onycholosis is this, where there will be a painless detachment of the nail from the nail bed. So if you happen to see this, and then if this patient is in your clinic with joint pain, with suspected psoriasis, please send him to a doctor. No, let him get the medical treatment first. Okay, because if he's let to worsen, then at some point there will be irreversible joint damage which needs total knee replacement. Okay, dactylitis and enthesitis. These are all the symptoms of psoriatic arthritis. You see, as I mentioned, the DIP is more commonly involved in psoriatic arthritis. MCP and PAP is involved in which arthritis? Rheumatoid arthritis. whereas in psoriatic arthritis, DAP is commonly involved. And again, it's oligoarticular in nature. It won't affect bilaterally, symmetrically all joints. It affects only few joints. That's one of the hallmark sign of psoriatic arthritis. But again, it has various sub patterns like RA pattern is there, ankylosing spondylitis pattern is there. Let me not go deep into that, but DAP pattern is there, and some pattern where there will be an erosion of the joint itself, erosion of the bone itself. The long bones will become very thin, and it becomes almost obliterated. So these are the subtypes of psoriatic arthritis. Now, there is no one single test to diagnose psoriatic arthritis. You just have to clinically correlate. Now, how? Because it's an seronegative, RA and anti-CCP will be negative. X-ray will be showing, rule out ANA because that is for systemic lupus erythematosus. With clinical pattern, with joint manifestation, with X-ray findings, so they can diagnose it as psoriatic arthritis. But psoriatic arthritis, once medically they are managed well, then you must treat them by physical therapy means. There are certain do's and don'ts in psoriatic arthritis that we'll be discussing in the subsequent webinars. Okay, and finally, enteropathic arthritis in the spondyloarthropathic family. If the patient has had a recent inflammatory bowel disease or Crohn's disease or ulcerative colitis and then develop joint pain, then we think that, okay, it could be a enteropathic arthritis, okay, or IBD related. IBD means inflammatory bowel disease related arthritis. So negative RS, positive HLA-B27, males more commonly involved. Asymmetrical joint involvement. Monoarthritis means it will be affecting commonly only knees. Okay, and since it's bowel-related arthritis, it is not going to be very serious. It's non-deforming and non-erosive. All right, and this is the role of physical therapy is very minimal here because as the disease is controlled medically, the joint pain will go away. So there is no much scope of physiotherapy here. Now, gouty arthritis. Have you ever seen patients with gout, acute gout? People have come to you. I have got a patient, acute gout. Yeah, the pain level in gout is the worst pain, especially when they get some small hit. Let's say that the first MTP joint is the commonly involved joint in gout. You all know that. People in Bangalore, at least people in the cities, they know that gout is due to uric acid, and by default nowadays any joint pain the doctors are referring for uric acid test. So in that way, some of the patients are screened. But again, some of the patients are overdiagnosed. Means they don't have gout, but just because they have little bit of elevated uric acid level, they brand him under the category of gout and then treat. But you need to have a proper clinical science with the blood test, and then you need to correlate. Okay, it can happen either way. Patient may not have gout, and he will be getting treatment for gout. Patient will be misdiagnosed for a gout. Okay. Now, why it's happening? Because of excess accumulation of monosodium urate, which is nothing but a crystal deposit as a result of excess uric acid in the blood. It's a non-autoimmune, means unlike RA, it is not an autoimmune disorder. It's due to the problem with the metabolism. Okay, there is an excessive production of uric acid, or there is an excessive production of uric acid or reduced excretion of uric acid that results in accumulation of uric acid in the blood, and then it goes to the joint. Now, risk factor, males are more commonly involved than the females. Obesity, kidney problem, and cancer medication. These are some of the risk factors for them to develop gout or gouty arthritis. Earlier days it was called as disease of kings. Why? Because in those days only kings were affordable. Kings were affordable for beer, high sugar content foods, and meat. Okay, which is going to increase the risk of accumulating uric acid in the blood, because if the food is high in purine content, then there is a likelihood of accumulating uric acid in your body. So there are people who would say that having 5 to 6 beers in a day, the next day morning or the same day night when they wake up, they'll have severe pain in the food, because suddenly there will be an elevation in the uric acid level in the body, which can cause acute attack. That's the reason why gout is always acute. Patient come to you with a pain history of 1 day pain or 2 days pain, because the pain will be so severe that they cannot tolerate. They will definitely meet the doctor. Okay, pain is one thing that led patients to meet the doctor. Now, I would like to add this today. I saw a frozen shoulder patient. She is a stiffness dominant frozen shoulder. It's not pain dominant frozen shoulder, only stiffness dominant. So pain is not a problem, but the family people were worried about the stiffness, so they got her in. This lady, she didn't care about the joint stiffness. She said, "I'm fine." She's 60 plus, so I'm fine, doctor. Whatever I'm able to do, I'm doing. So I don't need any physical therapy because there is no pain. So you need to know that if there is no pain, hardly people come to you. Okay, pain is one thing which is the greatest driving factor, greatest motivating factor for the people to meet the doctor. So the pain is what? 10x. Okay, 10x pain. If normally ONE pain is 7 to 8, this will be more than that. It will be 17 or 18 like that. Okay. So why first the MTP is affected? Any guess? Why not knee joint? Why not hip joint? Why not shoulder joint? Because it's a crystal formation. Because the liquid will become solid. For the liquid to become solid crystals, you need low temperature. Now, where is the low temperature? The temperature is low in the core, or temperature is low in the periphery. The temperature is low in the periphery. Which is the periphery, most periphery in the body? The toe, because that's far away from the core, isn't it? That's why. So this uric acid or the sodium monosodium urate crystals are depositing in the first MTP joint, not in the hip joint or the shoulder joint. And again, it's always monoarticular. It won't come bilaterally symmetrical. It won't come as a form of chronic usually. Okay, and it's asymmetrical form of arthritis. Fine. Though it's a disease of king, nowadays, everybody is our king now, isn't it? Everybody are king. At least in the city, everybody are king. They have access to beer. They have access to high sugar drinks. They have access to the meat. So it can happen to anybody. You will get all kinds of inflammation in psoriatic arthritis, rheumatological, functional everything. Little bit of low-grade fever, and the moment there is a direct hit on the bone, it causes tremendous pain. 10 of 10. Okay, and there is something called chronic gout. If acute gout is not treated properly, patients will get recurrence of gouts. They get every 3 months, every 6 months. They'll keep on getting the episodes, and finally they go into the chronic gout state. And there will be no pain between the attacks. Now you see the MTP. It's far away from the center, so MTP is the most commonly affected joint. All right. Now, pathophysiology, as I mentioned, there will be excessive production of uric acid, or there will be a reduced excretion of uric acid by the kidney. So that means even in kidney dysfunction, you will have tendency to develop gout. All right. Fine. This blood test, now what is the normal value? 3.5 to 7 milligram per deciliter. If anything beyond 7, then you can think of, it can be 7, it can be even 7.5, but clinically they should have gout, isn't it? Don't think that just blood-wise you have 7.5 doesn't mean that whatever, if you have 7.5 and if you have a hip pain, don't diagnose him as gout. Okay, that it happens now because people, the physicians will always look for blood parameters. They don't have much time for physical examination. So sometimes I tell, okay, your blood value says this, but clinically you have this, so you have this, not that. So it takes some knowledge to convince them, because knowledge is very important for you to transfer it to the patient so that they get confidence in you. Fine. So you need to rule out if there is any monoarthritis. You need to also rule out septic arthritis, which I'll be discussing in the next slide. Fine. Have you seen this picture earlier? Okay. Last 2 years, I have seen 2 patients. Now it's not something which will be happening every day in your clinic. Usually, even with this pain, patients don't come to physiotherapy because they would have already Googled and they have known that they have got gout and they would have straight away gone to their physician. Okay, so this is the common. You see swelling, redness, erythema, classic signs of inflammation. First MTP joint. Okay, what is this? This is chronic gout. Okay, we call that as tophi, where the crystals don't get dissolved, and crystals will keep on accumulated, and it will affect the morphology of the joint itself. Okay, and again, this is very rare phenomena because the treatments are very advanced now, so this should not happen to patients nowadays. Treatment, you all know that. Now, for uric acid specific drug, allopurinol and probenecid are the 2 medicines that are commonly given. One is to reduce the uric acid production, one is to increase the excretion. Diet is important. Don't take beer, don't take alcohol, reduce meat consumption and the soft drinks. Okay. Okay, one small slide about pseudogout, because in gout, which is a crystal? Monosodium urate. In pseudogout, it's calcium pyrophosphate dihydrate. Why? Excessive calcium accumulation in the body, excessive calcium metabolism in cases of, let's say, hypothyroidism or hyperparathyroidism, or hemochromatosis, where there will be an accumulation of calcium in the body, so that there will be an excessive cartilage. This is called as chondrocalcinosis, too much of calcium in the joint. Okay. Unlike the gout, it affects the wrist and MCP joint. It doesn't affect the great toe, it affects the MCP and the wrist joint. But it will fall into the category of inflammatory arthritis. Okay. And pain is also not as severe as gout. Fine. Sorry, time, 6:50. Okay. Fine. Now, SLE, let me go through fast. It's again an autoimmune disorder. It has a strong genetic association. Has environmental triggers, smoking, infection, X-rays, medications, and estrogen. What is the hallmark sign? Anti-nuclear antibody. No, the body will develop anti-nuclear antibodies. Means antibodies will be developed against the own body cells to kill them and to produce inflammation. Females are more common involved, and you see, this is the classic butterfly rashes. The moment you see this in the patients, you need to think of SLE, because this is so much for SLE. Plus, they'll have other organs involved. SLE stands for systemic lupus erythematosus. Means systemic means it affects every system in the body. Lupus means it's in English lupus. In Greek, lupus means wolf, because it looks like a wolf bite. Erythematosus is the redness, okay, out of erythemia. Alright, so it looks like a wolf bite, that's what they say, but it's a misnomer. So it can affect every system in the body: heart, kidney, brain, blood, and so on. And 90% of the SLE has arthritis. Now, though the disease is controlled by medication, who will treat the arthritis? Physical therapists must treat the arthritis, especially when they have gone to a inflammatory to a biomechanical state. Then physical therapists must treat this. Okay, blood test. ANA is the one single most test. If the ANA is positive, very specific test for SLE. If ANA is positive, and if DNA is positive, then it's confirmative of SLE. Okay. As I said, it can affect every system in the body. The treatment is that you treat the systems which are affected, plus you treat by disease-modifying drugs. Okay. Septic arthritis, it can be due to any infection in the joint. See, there's a difference between septic arthritis and reactive arthritis. We discussed reactive arthritis is the result of previous infection. It can affect any joint. Okay, whereas septic arthritis affects only one joint. Let's say TB or TB hip, TB osteomyelitis knee joint. Okay, so it can affect only one joint: monoarthritis, inflammatory arthritis. Other names of septic arthritis are infective, pyogenic, and suppurative arthritis. What are the common agents? Bacteria are like Gonorrhea, Streptococcus. Staphylococcus is usually from the lungs. Streptococcus is usually from the heart. People with endocarditis, they will develop septic arthritis. People with upper respiratory lung disease, they can develop this, because from the lung, it will go to the bloodstream. From the bloodstream, it can go to the joint. Commonly, knee is involved. And most of the septic arthritis involves knee joint. I don't know the reason why, because they say the knee joint synovium is very much thin, and most of the synovium doesn't have basement membrane. So the infectants, the microbes can easily penetrate the synovium of the knee joint. Okay, now if somebody comes to you like this, okay, please don't give ultrasound or IFT, because it's so apparent that it's something wrong going on in the joint. Okay, ask the history, how long they are having any recent history of trauma. Probably you can refer them for a physician or a rheumatologist. Okay, so previous fungal bacterial infection, it can be due to even dry. There was a case study where a patient got hip joint septicemia following dry needling. I don't know how true the study is, but there was a literature about the hip joint getting septic arthritis as a result of dry needling. Not only dry needling, any surgery can see. ACL surgery can cause septic arthritis in the knee joint. Okay, or any heterogenic procedures can cause septic arthritis. Osteomyelitis can invade into the joint, can cause septic arthritis. And TB, don't ignore TB. Okay, TB is a silent condition. All of a sudden, it will strike. After a long period of dormant stage, it can suddenly become active and it can affect the joint. Okay, that's about the septic arthritis. Acute, very hot, tender, unable to move. Knee joints are more commonly involved. Investigation, WBC. The one hallmark sign is WBC is very high, more than 1 lakh cells per cubic millimeter of the synovial fluid. So synovial fluid aspiration is one of the major tests for septic arthritis. Okay, who got viral arthritis? Okay, I got viral arthritis. Let's say 2 years back, I got viral arthritis. You know what? I suffered for past. I suffered for 3 close months. Okay, I did take medicines. Couple of weeks, because once you get viral arthritis, post-viral arthritis like chikungunya, rubella, there are people who come in wheelchairs. People who come in stretchers sometimes, they're unable to get up in the morning is one of the hallmark signs. Very painful arthritis, and some of the viral arthritis cannot be even diagnosed by blood tests, because some tests are not very sensitive for certain viruses. But the moment you hear about I got fever got all right, but I got joint pain. Okay, blindly you can say it's post-viral arthritis. It will run its course. Okay, you cannot do anything for reducing the duration, but you can reduce the pain, you can reduce the disability with medications and with physical therapy. Because I have seen patients who got viral arthritis, all the joint pain have vanished except the ankle joint. Okay, some joint will get what do you call, more recalcitrant in terms of the disease, in terms of the stiffness. At some point, it will become biomechanical. So you need to mobilize the joint, you need to loosen up the joint, you need to get the range of motion happening. Probably here and there some soft tissue work is needed in order to free up the joint. So if they say that I got the fever and then I got joint arthritis, all the joint pain have gone, but one joint, my ankle joint, is still stiff. Physical therapy is important in that case. Okay, in 2-3 sessions you can quickly reduce the inflammatory exudates and make the joint more mobile. All right. Otherwise, everything is common. All the symptoms of viral arthritis will be there. Let me not dwell deep. You can you can see that later. The video will be sharing later to you. And people who are, if you are taking snapshots, no need of taking snapshots, because we are going to provide this video later on for you, so you don't have to bother yourself in taking snapshots. History, clinical pattern, IgM antibodies. These are some of the diagnostic tests that you do for this. Lastly, hemophilic arthritis, very not so common in India, but in Western world it's common. If you see a young guy with a history of hemophilia, 70% of the time you will get arthritis. So it's better to avoid getting this to this stage. Physiotherapy treatment is quite imminent here. Price protocol in the initial stages, and then gradually we'll be discussing the treatment later on during the next subsequent webinars. But do understand that hemophilia can cause arthritis. Fine. Now, I think I'm done. And for the completion's sake, yeah, neuropathic joints are there, but it's not under the inflammatory category. It's under non-inflammatory, but still it needs physical intervention. Okay, it's Charcot's foot. You might have heard, due to lack of sensation in the joint will get damaged, subluxed, and injured. So that needs PT intervention later on. Fine. Now I will hand over to Dr. Sasi Kumar. He'll be talking about medical management. You need to know a little bit about DMRD, some common names, but what is Newcoxia, what is biologics, a little bit orientation that you need to know. That's the reason why he's going to talk to you for another 5 minutes, at least 5 to 10 minutes maybe. After that, we'll conclude this. Okay, I'm handing over to Dr. Sasi.
Thank you, Dr. Rajkaran sir. Good evening to everybody. Pleasure to be here. First of all, I special thanks to Dr. Chandrasekhara, because more than 15 years I am working with him. He guiding proper way to me. And also thanks to Dr. Rajkaran and Dr. Muhammad Qasim sir, because of they motivated always for me. Then I got little bit more amount of medical aspect of the medical management in rheumatological and immunological conditions. So I am presenting what I learning knowledge about rheumatological and immunological conditions to here. So please listening to my knowledge of medical and medical management of rheumatological and immunological conditions. So presenting following objectives includes why medical management is important, who prescribe the medicines, what are the types of medicines prescribed, how this knowledge is useful to physios. Then why medical management? Most of the rheumatological conditions are inflammatory and are autoimmune in nature, which needs medicines to control it. Inflammation is the primary factor for the causes of the disease and its progression. Medically, anti-inflammatory is mandatory. Autoimmune disorders needs physiological regulation of antigen and antibody, which can be dealt by immunosuppressants. Though can't be completely cured, that disease progressions can be satisfactorily controlled by medications. The medications is very essential in preventing irreversible joint erosion, damages, subluxations, and subsequent morbidity and mortality. So without any medical interventions, will never cure all the medical rheumatological conditions. Then next go, I'm talking about who prescribes medicines. Rheumatologists and immunologists are most eligible, equipped, and efficient understanding the disease nature, blood parameters, and physical examination of the patients. They administer the right drug in right dosage, in right combination, and in right time. They understand the effects and side effects of each drug. That's why they are sometimes they are reduce the dosages and increase the dosages. They are doing like this. Orthopedicians and general physicians do treat, but not that much of skillful like rheumatologists. And homeopathy and Ayurvedic practitioners claim to cure, but scientifically not proven. Sometimes it will happen irreversible joint damages and permanently joint stiffness also. So meet your right doctor at the right time. Next, I'm going to talk about what are the types of medicines. These are all list of some medications include like NSAIDs, DMRs, steroids, biologics, supplements. So what are the NSAIDs? It is otherwise called it as non-steroidal anti-inflammatory drugs. It is classified 4 types: non-selective COX inhibitors, preferential COX-2 inhibitors, selective COX-2 inhibitors, and analgesic antibiotic types. So commonly in my hospital, patients getting heterocoxic and celecoxic like Nicoxia and Celadala. So these are 2 medications. Timing they are using. After that, slowly we go for SOS basis. So what is the actions of NSAIDs? There are 3 actions coming. Analgesics means it tends to reduce the pain. Anti-inflammatory it tends to reduce the inflammatory, and antipyretic it tends to reduce the fever and all like this. So next I'm going to talk about DMRDs. So this is nothing but otherwise call it as disease modifying anti-rheumatic drugs. This is one who drug using to control or further the prevention of the disease damage and progressions. It indicated mainly for rheumatological disease, for example, rheumatoid arthritis, spondyloarthropathy, and connective tissue disorders. It given to long-term treatment. For example, minimum 2 years treatment. Sometimes it will extend from 5 years. So this is very, very important treatment in case of rheumatological and immunological conditions. What actions of DMRs? So mainly it's regulate the immune system and suppression the immune system. Few examples of DMRs like methotrexate, hydroxychloroquine, leflunomide, sulfasalazine, azathioprine, mycophenolate mofetil, and tacrolimus. This is contains name. In brand name is like Polytrax, HCQs, Lefuno, SAS, Azoran, MMF, and tacrolimus. In case of rheumatoid arthritis, that Polytrax, HCQs, Lefuno, and tacrocard they are using alternatively. Nowadays, that HCQ is also using that prophylaxis of COVID patients. Then, in case of ankylosing, is best treatment, best medications of SARS. And azathioprine like Azoran and MMF commonly using of in case of SLE. So means systemic lupus erythematosus. So what is the biologics? Biologics is products produced from human, animal, or microorganism by using biotechnologies. This is most effective treatment. This effective is very important for nowadays. Only drawback is that cost factor concern. Few examples of biologics like infliximab, we are using ankylosing spondylitis on rheumatoid patients. Rituximab, they are using rheumatoid arthritis patients. Adalimumab, in case of ankylosing and rheumatoid arthritis patient. Etanercept or Enbrel, mainly using for ankylosing spondylitis. In psoriatic arthritis patients, mainly using for secukinumab. This is common for biologics. So what are all common side effects of NSAIDs, DMARDs, and biologics? May you know all hair loss, and nausea, vomiting, allergic reaction, chills, weakness, rashes, itching, and headache, fever, shortness of breath, and muscle pain, and eye issues like blurred visions or rashes and eye pain, etc. So next, I'm going to talking about steroids. In case of DMRs and anti-NSAIDs is not able to working properly, that short course of steroid will using for this one. So what are the steroids? Steroids, synthetic form of the corticosteroids that are used in inflammatory conditions. It suppresses the inflammation and the immune system. Its action is fastly, quick improvement and easy to administer. They are using form of orally and injections like this. Some examples of steroids like prednisone, methylprednisolone, dexamethasone, and hydrocortisone. What are all common side effects of steroids like weight gain, acne, facial puffiness, hypertension, headache, muscle weakness, and lack of sleeping disturbances? Then next go for supplements. So in case of all the immunological and rheumatological treatments during prolongedly, maybe patients will get in later more than 5 years or 7 years, patients maybe will get bone weakness like osteoporosis and anemia, some other disturbances. So that time supplement really is required. For examples of supplements like folic acid, calcium, vitamin D, glucosamine, and diet. So these are all common supplements for in case of rheumatological and immunological. For example, like diet means we are using mainly calcium-rich food like milk products, then anti-inflammatory diet like fatty fish, green leaves, vegetables, and dry fruits like this. So nowadays, all are after 35 years definitely getting vitamin deficiency and calcium deficiency. So that's what before that we are starting calcium and vitamin supplement also. Then how this knowledge is useful to physio. For the physio to be aware that the patient is medically in the right path, to speak a common language and for a better communication with rheumatologist. For example, in my hospital, my doctor know how he knows what is the physiotherapy, what type of physiotherapy modalities using like ultrasonic massage therapy, wax therapy, drain needling, McKenzie type of technique. Similar to we also knows what is the methotrexate and what is the effects of methotrexate and hydroxychloroquine. That time easy communications with the rheumatologist happens. Then we gain patients' confidence if we talk about medicines. Anyway, in my hospitals, my doctors per day seeing more than 100 patients. We don't have that much time. So directly patients are coming to our department. We are explaining about what are all medications, what is the side effects and the uses of medications. We are explaining each and everything. That time patients also get confidence and they are also giving respect to us. So that purpose only medical knowledge is very important for our physios. Then helpful in clearing doubts in case of patients have any doubts about medicines. So finally, physios must clinically assess the inflammatory status now and then and must refer to a doctor for the dosage modifications. So these are all my medical knowledge about in rheumatological and immunological conditions. Thank you for listening. If any doubt, you can please ask me in end sections. Thank you very much. Next, back to Dr. Rajkanan. Thank you very much.
Thank you, Dr. Sasi. Dr. Sasi has got a tremendous understanding of how these medicines help in this patient because he has been spending all his career in the field of rheumatology. So, if you people have any doubts in any conditions, any patients, you can also call him directly. He'll be of great help whenever you call him. Thank you, Dr. Sasi, once again. Okay, so it's summary time. What we discussed today was inflammatory and non-inflammatory disorders. We didn't touch little part of non-inflammatory disorders. Fibromyalgia, osteoarthritis are different topics for some other day. But I hope you got some fundamental knowledge about inflammatory disorders. What are its basic presentations? How to discriminate one from the other? When to refer and when to treat, which we'll be discussing further upon during the subsequent webinars about when to treat and how to treat and so on. There are other connective tissue disorders as well. Rheumatology is a vast field, as I said. About 100 types of disorders are there. We'll not be having time to see everything, but do understand polymyositis, dermatomyositis, scleroderma. They have some physiotherapy role, which is not complete, which is not considered all these days. So, as I said, it's a huge potential to tap, which we will be tapping in the near future. Okay. Now, what is in part B? Now, because in the invitation we mentioned that it's clinical part A, because before we tell about the treatment to rheumatoid arthritis, treatment to SLE, treatment to psoriatic arthritis, I thought we must imbibe some basic understanding about the clinical part. That was the reason behind this webinar. We wanted to little orientate the people about the clinical part. But in reality, the therapy part is most important for us. So in part B, we'll be discussing on scope and principles of physical therapy treatment in individual rheumatological conditions. Because we see these cases every day. It's not like these are all virtual patients. We see that every day. Sasi Kumar see patients every day, and we are going to share such treatment experiences to you in the near future. Probably sometime next year we'll be doing. We'll be showing the real-time videos of how we assess and treat the patients, and also the individual treatment protocols and many more in the therapy series, because I don't know we'll be able to cover everything in a single session. That's why I mentioned as therapy series. Fine. Thanks for listening.